Welcome everybody to Fitfoot U. I'm Dr. Ben Pearl, and today I have Clifton Bradley. He is an elite runner, formerly with Great Britain and England, and he had a trajectory that took him on a path to examine his own injury. I'm not going to steal his thunder. I'm going to let him talk all about it. He's a podiatrist and has a pretty cool gadget to look at digitally pelvic asymmetry. Welcome, Clifton.
Hi, Ben. How are you doing?
I'm doing well. And tell us about how the path got started.
Okay. Firstly, thank you so much for inviting me to talk with you. It's a real honor for me. I guess I kind of got to this point where I'm talking with you as a podiatrist after an injury as an athlete. I then went to Iowa State University on a sports scholarship. And the athletic department, the sports injury department, sent me with Danny Harris. I don't know whether you remember Danny Harris. He was like the Olympic silver medalist in the '84 Olympics behind Ed Moses. He and I went to see a New York podiatrist, and I wish I knew who it was, but it was a long time ago, and I wasn't thinking about podiatry then. But they did a biomechanical assessment on me and gave me orthotics, which were awful. I've got to be honest, I didn't wear them. But when the realization that my kind of international running career was over, I was talking to a pal, and he said, "Luke, why don't you train to be a podiatrist?" And I just went, "Yeah, okay, I'll do it." Went to podiatry school. I had no idea what they did. I thought it was just going to be kind of trimming toenails and paring away hard skin, and then one day on the timetable, it had this magical word, biomechanics. And I had no idea that we were going to be doing that stuff. So I went into the lecture, saw what they did. And I was known as, in England and Great Britain athletes. I'd just broken the British record for the mile just before I got injured. I ran a 3:57 mile. That was the first Englishman to do a sub 4-minute mile on an indoor track. And people were like, send the runners to him. He's a runner. So I was faced with all these runners, didn't really know, well, obviously didn't know what I was doing with these runners. And I've been learning ever since the last 35 years. But I absolutely fell in love with biomechanics and sports injuries and sports biomechanics and assisting my fellow runners and obviously sports people. And I've had a 35-year career. And even this morning, Ben, I was up. I set my alarm at 6 o'clock every morning. I still have the drive and discipline of an athlete. It's a pain in the ass, I can tell you, because it drives you to do all this crazy stuff. And so I spend an hour every morning studying. I generally spend an hour at night. And my passion for musculoskeletal biomechanics is as strong today, if not stronger, than it was with my first patient 35 years ago.
I'll tell you what keeps me going, honestly, is talking with individuals like you. I've had the benefit of talking to people internationally, as well as here in the US, and the exchange of ideas. It's good for everyone. It's good for listeners. It's good for me. It's good for the person being interviewed, because it forces us to remain engaged. And particularly here with the US managed care, let's face it, patients, we went into this to help patients. Depending on the subset that you are helping, it can be challenging. They come in with some baggage sometimes, and we have to sort of unpack that. Before we get too far afield with, really with the meat of the talk, tell us why it's a little more challenging to accomplish a sub 4 on an indoor track. What are the mechanics of that, the track mechanics?
Okay. Well, I didn't know my biomechanics, obviously, as an athlete. I mean, I started running when I was raised in Australia. So I was raised on the side of a mountain in Queensland, on the Glasshouse Mountains, on Buderim Mountain in particular, one of 8 children. My dad went over to find his fortune as a computer engineer. So we didn't have a lot of money at all. We didn't wear shoes. I didn't wear shoes until I was about 9 when I came back to the UK. That's where I discovered my love of running. Came to the UK, realized I just had this natural ability to run and needed to be trained. I had a fantastic coach, Harry Harvey, Olympic coach, just happened to be up the road. So he trained me all the way through schools, collegiate, then onto the proper Great Britain team with the likes of Sebastian Coe and Steve Ovett, who at the time were Olympic medalists, and I was following their foot track. But I didn't know my biomechanics because biomechanics was very new then. It had only just come to the UK. But I was fast off the bend. I was tactically quite good. I had a lot of natural talent. My coach was holding me back with training, because he was like, your time will come. But I noticed that I was fast off the bend. And as it turned out, we run anti-clockwise on an outdoor track. I was a 1,500-meter runner. But the reason why I was fast off the bend, as it turned out, I've got a longer right leg. I have a structurally long right leg of about 8 mil. So therefore, going around the bend anti-clockwise, it pushes your center of mass around the bend. And I always used to have an ache in my right knee. And it was probably because it was flexing more and there was other adaptations to the asymmetry. But anyway, jump forward a few years, I was developing behind some of these great athletes, and you're going to be the next Sebastian Coe type of thing. There was a lot of pressure on athletics at the time because it was a big commercial sport. It was massively televised because we had all these Olympic champions in the UK. So one day I get this phone call: Sebastian Coe is injured. Can you take his place? I'm like, let me think about it for a second. Obviously, it took no time at all. So I did, to cut a long story short, I ran this race, took Seb's place against USA in the indoor match at Cosford. It was the only indoor track in the UK.
What year was that?
It was RAF Cosford in the UK, and it was the only indoor track we had.
And approximately what year?
It was 1985. It was March the 9th, 1985. And the soldiers had built this indoor track, and they made it too cambered. And again, at this point, I didn't know that I had a long right leg. So there's 8 laps in a mile on an outdoor track, but 16 bends on an indoor track because it's a 200-meter track. So 16 times round, a highly cambered track up to the right with my long right leg split my pubic symphysis. So I did a lap of honor. I just ran 3:57 mile, broke the British record. But obviously that camber on a long right leg puts so much torque and force and newtons through the foot into the knee, into the acetabulum, creates a massive torsion in the pelvis, and my pubic symphysis split and wiped out my career.
Now you're going, you said clockwise. Did I get that right on the indoor track?
Anti-clockwise.
Oh, anti-clockwise. Anti-clockwise.
Yeah.
And then a normal outdoor track is also anti-clockwise.
So a long right leg on an outdoor track is an advantage on the bend. A long right leg on an indoor track is a disadvantage on the bend because you're raised up. So a long left leg on an outdoor track is a disadvantage because you have more ground reaction force under the longer limb, and you'd have to have an earlier heel lift and more extension on the shorter limb, which would be the outside leg, wouldn't it? But on an indoor track, a longer left leg down the camber going anti-clockwise is an advantage until you hit the straight. So, but just for me personally, it split my pelvis. I broke the British record. I didn't think it was going to be a big issue, but a year later, still injured. Went to America, came back after a year, still injured. It took 4 years, and by which time the window had closed. That international athletics window had closed. I went to become a podiatrist and specialized in running injuries.
Not to belabor it too much, but just so our listeners and I understand completely, I get what you're saying. You're kind of leveling out if you had the longer left leg on the indoor track, whereas you're the high side is even higher because of the long
Yeah.
right leg.
Yeah.
What does that do, though, to the force distribution transfer in the stride, in a nutshell?
Yeah. I mean, especially on a bend, and determined by the material under the surface of the track, you know, the tartan surface, and the angle of the bend. Obviously, in the olden days, they didn't really have a standardized camber like they do today, and the tracks are sprung today. You know, so there's much less impact on the joints because athletes just used to get so injured back in the day because the track camber was wrong, and it was concrete with just tartan on top, the red tartan. But the forces, the magnitude of the force going up through a longer limb going anti-clockwise on an increased cambered track is so, and I can't quote you the exact numbers, but the magnitude would be so asymmetrical that you know, think about those forces to overcome the viability of an amphiarthrodial joint, of that fibrocartilaginous pad that sits between each anomalous of the pubic symphysis. The magnitude of force to split that joint would have to have been several thousands of newtons. And there's been a research paper talking about displacement of sacroiliac joints. I haven't seen any on pubic symphysis specifically. And this one paper said that it took about 3,300 newtons to displace a sacroiliac joint when, you know, when osteopaths and chiropractors talk about upslips, which I don't actually buy in most people because the forces would have to be so great. But running at sub 4 minute mile pace on a camber is enough force, clearly, because it split my pelvis, you know, and very sadly wiped out my career. But I wouldn't have this amazing musculoskeletal career as a podiatrist if it wasn't for that injury, you know, just transferring that energy and positivity to my career.
And what was a couple of the epiphanies along the way of your journey with discovering what to do with pelvic asymmetry? Maybe give us a couple highlight of points that you had, that the light bulb, this is what I need to do. This is how I need to measure.
That is exactly what it was, Ben. And it was an absolute light bulb moment. And it changed my life as a practitioner and changed my life in many other ways as well. And what happened was, you know, you're at podiatry school, and 35 years ago, we were taught about, you know, anatomy in isolation, function in isolation, but also as well as, like, you know, I was told, you know, and the training was good then for where we were 30 odd years ago, almost 40 years ago. It's like you look at the heel in the frontal plane. So get down low behind your client on the treadmill and look at the heel in the frontal plane and measure subtalar neutral. Obviously, you know, finding the axis of subtalar joint static doesn't exist. What we were taught then, right, you measure the subtalar joint like this, you draw lines on the calf, you draw lines on the heel, you look at the back of the heel. No one ever talked about sagittal plane. No one ever talked about pelvis. So what happened to me, that light bulb moment, was runners were coming to me in large numbers, like, you know, Clifton, you're a practitioner, and you just broke the British record, fix me. So I had to learn fast, and I really didn't know what I was doing. I was green as anything, thought I knew everything, realizing now looking back I knew nothing. But just, I kept on noticing that, okay, I was trying to do what I was taught and trying to put some values to the subtalar joint, which I don't now, obviously. But I kept on finding that injuries were asymmetrical. I was looking at foot function and finding symmetry much of the time and asymmetry some of the time in the lower limb, obviously, as we do. And one day I just thought something else is going on here. It didn't make sense. What I was taught didn't make sense at the coalface. The reality of injury didn't make sense with what I'd been taught for 3 years, and it really frustrated me. One day I had an athlete walking on my treadmill. I stood at the side talking to them, and I just said, can I put my hand on the side of your pelvis? Obviously warning the client I was going to put my hand on the PCs to axis, PCs to ACIS, anterior superior iliac spine to posterior iliac spine, bony prominences. placed my hand on the pelvis. I felt I felt the movement, didn't know what it was. I can't remember what it was on that patient, but I couldn't remember what it was. Walked around to the other side, did the same on the other side, tried to do what I call now motion palpation, feeling the pelvic movement. And I thought, hang on, the right side is completely different to the left side, and they have an asymmetric injury. Didn't think anything more of it because I had no idea what I was looking at, and there was nowhere I could go to, and there was very little research, very little in the textbooks. Saw that many times, and then went to Brian Walker, who at the time was the Man United osteopath, who I was just starting to acquaint. And I said, Brian, I keep seeing this pattern on the pelvis, this posterior rotation on one side and anterior rotation on the other. What is it? And he just looked at me and said, well, I know what posterior rotation is, and I know what anterior rotation is, but I've never seen that pattern. So after, when you're a few years in and you've done a few hundred of those motion palpation assessments, I started to see other patterns, and then went to my DIY store and bought a laser level. So I was standing up people against the wall with a laser level. Then I was buying little digital inclinometers and sticking them on bits of wood and trying to kind of get a measurement, which I couldn't do. So I went to a precision engineer in my local town and said, look, this is the idea I have in my head. I need to have something stable. I need to have a spirit level on so I can get a reference plane. And I need an accurate way of measuring the angle. And I need somewhere to put my hands. And I've still got that same prototype on display at my practice with other prototypes. And eventually developed a digital pelvic inclinometer. And it allowed me to then measure one side, measure the other side, and come up with the difference that is the pelvic torsion. So, years are passing by now and a few hundreds of assessments, but I started to see number patterns associated with specific injuries and specific motion patterns within the body and pathomechanics. And to date, I've measured over 15,000 pelvi and have a clear idea in my head of how pelvic motion works with lower limb motion. And if you look at the research, imagine a big jigsaw puzzle of how this all works. And we don't know the full jigsaw puzzle in any aspect of biomechanics. But we're starting to put pieces in this jigsaw puzzle, aren't we? As practitioners, we've got clear images. We educate ourselves and we go to conferences and we're educated at the universities and we do our learning and we cross-reference with other professions. So we're building this picture, aren't we? But there's still chunks missing. And one of those chunks that are missing is thorough understanding of pelvic engineering. And because of what happened to me as an athlete 35 years ago, and my passion for sport, and especially running, I've been trying to put those pieces of the jigsaw puzzle together and getting close.
Now, the key with any measurement tool is making sure that we are dialing in on the landmarks. What assures that consistency? I understand you're using a laser.
Yeah.
How does that tabulate the pelvic landmarks? And I guess the simplest terms that you can explain, because without you doing a workshop right here in front of us, it's probably a little hard to describe, but to the best you can.
Well, in first principle thinking, let me build a case. Okay, so everyone's an expert on leg length, right? Everywhere I go around the world, everyone's an expert on leg length, but no one really understands leg length. When I talk to people about leg length, they tend to give me two types of leg length. You've either got a structural anatomical difference in leg length, or you've got a functional difference in leg length. Asymmetry in the engineering of the pelvis and leg length is incredibly complicated, but it can be boiled down to some basic principles, but it cannot be as simple as two different types. It really can't. I've tried to, again, first principle this, and there are structural anatomical differences for a variety of reasons, whether it's part of your genotype or you've fractured your bone. There are rotational asymmetries in leg length. And an example of that is you can look at somebody and think, you've got a long right leg. How does that feel with that raise? Oh, it feels better. And you swear blind that's a long right leg. But if you measured the pelvis sagittally, you'd find out that actually it could be a hyper adaptation for a longer left leg. And I see that mistake made all the time. So you have rotational differences in leg length because of adaptation. And you can also have rotational asymmetries because of trauma. So if you fell off your bike, you're cycling down the road, fall off your bike, you'd have to fall in a particular place for the pelvis to go in that direction. So for a posterior rotation, you'd have to fall on the front of your pelvis, wouldn't you? And it knocks the pelvis bang into a posterior rotation. Or you fall on your back and you hit the back of your pelvis and bang, it knocks it into an anterior rotation. So, but the only way you know that is through measurement. So you go to the chiropractor or osteopath, and I'm fans of both. And they say, oh, you've got a posterior rotation on the couch. I'm going to put it back. Well, they've not measured it. So you can't put something back until you've quantified it, understood why it's in an abnormal position, because they're not out. They're just in an abnormal or a position or subluxation. And then I'm going to do my treatment, and I'm going to remeasure and say, oh, it's not moved, or yes, look, I've improved it. But then you need to hold it there. So the reference points are, Ben, is you need to do at least 2 planes of assessment on the pelvis to make any validation. You can't just view somebody from the front, and actually a view from the front is a massive misnomer on so many people, because you can see someone looks high on one side, you turn them around, do a 180, and they actually look high on the other side. That's because an inanimate bone acts like a boiled egg. You put a boiled egg on its side, it's low. Take the exact same boiled egg and it's high. The dimensions haven't changed, just its orientation. Well, if you've got 2 inanimate bones, an inanimate bone is very oval shaped and they're at different orientations. What you're seeing isn't what you're getting. So how do you overcome that problem? Firstly, you look at frontal plane, then you measure sagittal plane angle between the piscis and the asis, and then you look at the sacrum. There's only one sacrum. So you've got 2 wings, which can be variable, but one sacrum. The sacrum never lies. It is in a position. It may have a torsion, but it's in a position. So the thing I say to young practitioners is, whatever you do, do not make a decision on the pelvis from one plane. Look at both. The complexity there for somebody new to pelvic engineering is, what the hell do these angles mean? And you know, how did they get there? What does it mean right now? And how does it mean prognosing them functionally? How is it going to mean in the future? And do I need to intervene? So what do I mean by that? Is a posterior rotation will drop and internally rotate the acetabulum. An anterior rotation will raise and externally rotate the acetabulum. So you can get massive clues from the musculoskeletal system. So you know when you see one foot really excessively pronated and one in neutral or even supinated, look to the pelvis and you'll probably find on the side that's flat and excessively pronated, the pelvis is backwards. And what happens is the foot and the pelvis work together in a catch-22 to keep the foot flat and keep the pelvis backwards. So you're never going to correct it until you understand the forces going into the hip joint. On the other side, you can see an anterior rotation. And have you ever had patients say, I'm always going over on an ankle on one side?
Sure.
All the time, don't we? Do you have a predominance? Do you get clients that say more on one side than the other, say more on the right or more on the left? I'm always going over on the ankle.
For me, geez, that's people are right hand dominant. So if they're leading with it's kind of a double-edged sword. If they're leading with the right as their pivot point, that could be your spring off, and hence you could have the injury there. However, because most of us are left weak, there's that aspect of it. Most of us are left side. So I'm going not so much with what you're talking about with pelvic asymmetry, but with what I know about dominance and just strength.
Yeah.
So yeah, I would have to say that mildly, I think I get more left injuries, but I'm only going to say
Yeah.
mildly.
What I see, I see kind of more ankle inversion sprains on right, but I see more anterior rotations on right. It's called an acylium because you're measuring the pieces to aces on the ilium, so we call it an anterior superior ilium will raise and externally rotate the acetabulum. And if you've got axis of motion within subtalar joint that are sufficient for you to have those joint moments that just need that little bit of a force to tilt you over, the ankle will go, like walking down a cobbled street on an uneven surface. And there's lots of texts and lots in the research about the most common adaptation in the pelvis is a posterior left, anterior right. And we think the reason for that is, and a lot of this is anecdotal, that comes from me, although I do have a ton of research references around it, but just from my own personal experience, is whenever I travel around the world talking about this, and I talk to an old guy like me, and they're interested, they're fascinated by leg length, they'll always say they see more short right legs, and they'll always say they see more long left legs. And that's the thing. We don't know why, but it comes from when we come from being a quadruped, and a quadruped, like a dog or a cow, the organs in their abdomen form one center of mass. So it's central, regardless of where the heart is or where the stomach is or the diaphragm or the other internal organs. It's like carrying a bag of water. It will find one center of mass. However, if you then put that quadruped on two limbs, like we've evolved to do, those organs are now asymmetrical. So one theory is that we developed a longer left leg to balance center of mass. No one knows why. And let me give you an example of that. You just talked about dominance of right and left hand, and I found no link between handedness. But what's interesting is if you I'm going to give you a scenario, okay? So you go to gladiator school 2,000 years ago in the Roman Empire, and there's 100 new students at gladiator school, and the lead gladiator, who's survived many battles in the Colosseum, standing at the front, and he's about to train you. And he says, right, and there's 100 students. He says, there's 100 shields and 100 swords. Go and grab a shield and go and grab a sword. How many of those people would pick up the sword in the right hand? How many would therefore pick up the shield in the left hand?
I'm going to say 60 would take the 65. Let me say 70 would take the sword in the right hand.
Yeah, but why?
Because right hand dominance, that's the kill hand.
Yeah, but why? Well, think. Why would that happen? You look at quantitative genetics. P equals G plus E. The phenotype plus the genotype plus the environment. In that equation, you could say, why did these Roman soldiers most of them pick up the sword with the right hand? Well, go right back to hunter-gatherer times, way before the great cultural revolution of 10,000 years ago, when man went from being a farmer to being socialized. That's when we started to move from being hunter-gatherers to being, living in groups. But at the vent of bipedalism, I don't know exactly when that is, 2-3 million years ago, and we were literally, the only thing we had was a stick and a stone. We had no clothes. We had just become bipeds. We've been through these stages of evolution to not even get to Homo sapiens way before then. Homo sapiens are only about 300,000 or 400,000 years old. So you're there in this environment, and we survived because you and I are here having this conversation. How did they survive? How did they battle an animal or another hominid, for example? Okay. So if I was going to run at you now, if you and I were playing, if I came over to the States and you and I were going to play a game of American football, and I was going to run at you with the ball, which side would you face me with? You'd probably face me with your bent, strong leg. You wouldn't face me with your straight leg, because a straight leg is weaker than a flex leg with everything isometrically switched on. So if our ancestors had a predominance from being a quadruped of longer left legs, and in the gait cycle, there's greater time pressure integral of a longer leg on the ground than a shorter leg, because everything is flexed. So flexion lever arms keep a foot down, and therefore muscles like quads are isometrically, concentrically, and they contract more. So they become stronger than a shorter leg that would flex sooner and quicker, and the quad would become weak. So if you were going to run at me, I'm going to protect myself with my flex leg, and I'm going to grab a stick or a stone and bat you over the head with it. So the dexterity of the right hand could have come from a mechanical origin, in that you were protecting yourself by facing your enemy with your stronger flexed side. So jump to 2,000 years ago, when those Roman soldiers were told to pick up the sword and shield, because it had come through this phenotypic kind of environmental behavior, they were going to pick up the sword with the right hand. But that relates now to modern day musculoskeletal patients that you and I have seen. You know, the patterns of overuse injury match that behavior, but certainly pelvic position does, and that's well documented.
Well, I love that you're bringing up motor patterns, because it's something that you know, I've worked with as a ski coach when I was coaching skiing. I didn't reach the kind of running accomplishments that you did, but I was a walk-on at IU right after Jim Spivey.
Jim Spivey, legend.
But at any rate, I'm very interested in motor patterns and also motor signaling, and I've talked to you about what I'm interested in, particularly right now, is how electromagnetic neural signaling influences our motor patterns. And I'm also taking the holistic approach of patients that have fixed negative energy, negative thoughts that are perpetuating the injury cycle. And
the psychosocial aspects is massive.
There's a lot to what you're talking about, this whole phenotype expression, that I think is manifesting in a different way in our lifetimes by, you know, the signaling, the cell signaling that we're inputting. And whether it be cancer, whether it be neurologic deficit, etc.
That's why you and I love dealing with athletes, because they come in and they just got this aura of enthusiasm, and they do exactly what you ask them to do. They communicate with you clearly. They go up and do it. Sometimes you got to hold them back. But on the other end of the spectrum, you deal with a client who's massively overweight, not interested in activity, wants to give you some money and, like, you know, give me the magic wand and fix me. You know, they don't do the exercises. So it's like, you know, if you've got high energy, you know, like you do, and you've got clients coming in with high energy, you know, I'm not into crystals or mystical powers, but the reality is what you're talking about. There's those energies that they've got, and within the musculoskeletal system matches with yours, and you get high results because they're compliant. You know, there's an enthusiasm there.
Let me transfer for a moment to something that we see that I dealt with this week. And I like to throw like different things when I interview people. There's a lot of different thoughts about stress reaction syndrome, quote, shin splints, the Sharpie fibers, the anterior tib. It's usually a medial pattern with shin splints. And I have a patient that has that two-hand span right along the crest of the medial tibia. The interesting thing about him, though, is that he also is developing quasi symptoms that, like after the half-mile run, and it's interesting because before he had it bilaterally and he hasn't run in a year, but I asked him to do a half mile just to kind of get an update. After he had my assessment on ultrasound showed that he had some cortical minor stress reaction type symptoms, periosteal reaction. X-rays kind of the same, send him for an MRI. But where do you feel this idea now of because I'm sure you see it, and I'm sure whether symmetrical or asymmetrical, compartment syndrome, exercise induced. How have you been diagnosing it yourself? I know that some like the measurements with the internal pressures, the Stryker unit, so that you can get the internal compartment measurements. Kind of a tough test. A lot of people now are making the assessment clinically, but I sometimes find there seems to be this in-between stage where it's not necessarily that the compartment is blowing up, but that there does seem to be a time-related phase to the injury. What's your take on sorting that out?
I mean, firstly, for me, I don't do a specific measurement of the pressure, and unless everything fails. And then I would probably refer on for someone to do that, because I'm more interested in the movement pattern and the physiology. So I would probably get an orthopedic surgeon to do that. But most of the time I don't need to do that. But for me, I see the same patterns, and every client that I see, I'm looking for asymmetry. And humans are full of asymmetry. You know, when you talk to practitioners and say, I don't believe in leg length and I don't believe in asymmetry, I always say to patients, go somewhere else. Because every piece of living tissue on the planet is asymmetrical, especially human beings, you know, or including human beings. So, but I do see this pattern where if there's so much overuse, and a lot of it comes from increased time pressure integral, the longer that limb is on the ground, and the longer that you've got gravity meets the geophysics, you know, the geophysics of the planet meets ground reaction forces, you're going to get stress in a foot that has a medially deviated subtalar joint axis. And you palpate normally tibialis anterior and they're solid. But when you see it asymmetrically, again, look to the pelvis and you'll find there's a matching asymmetry at the pelvis. But compartment syndrome hates a kneecap that moves forward of the toes. So you'll often see it in a younger athlete that's doing road running. He's got poor quality shoes, often minimalistic shoes. So they've got too many excessive forces acting across subtalar joints. But you'll also see it in someone that doesn't run it, say works in a city or has recently started to work in a city. So let's say you get a job in Manchester or London. You're in smart leather-soled shoes and you don't take your car because you're in London. You take the tube. You're doing a lot more walking. And if you've got excessively stretched tricep surae, and you can see it in ex-athletes, I'm particularly overstretched because I've been running for 50 years. As soon as that kneecap goes flexes on a longer leg, goes forward at the toes, tibialis anterior becomes ineffective. And you get a reciprocal inhibition between tibialis anterior and the lateral side of the leg. You'll often find that there's hallux limitus and stiffness in the fibula head at the same time, and you'll get a compartment syndrome. So as soon as you address the mechanics, often the pressure will release. But occasionally I'll get an athlete or a patient where it just doesn't, and then you've got to send on for more medical interventions.
That's I knew I would get an interesting take, and I love that you are looking to other mechanisms like what you just mentioned with the kneecap and that anterior the inhibition with the anterior tib. And usually with these things, I think through them a couple times and process it, and then I try to integrate it. So that's good stuff, and I will be taking a look at that. Without giving away all your secret sauce, because I do want people to patron your Biomechanics Academy page and to follow up with some of the workshops and things that you're doing with your area of expertise. If I'm going in and I'm thinking about purchasing or taking a course with your pelvic asymmetry device, do I need to be fairly seasoned to get the experience as to palpate the landmarks? In other words, garbage in, garbage out. If we don't align the thing correctly, I'm thinking it's not just that it's reading it like if we were to go to 200,000, you know, $500,000 gate lab where they can put marks on the points, and then internally, this is something you can do within the office, and I'm sure it's filling in the lines with the laser, but what do I need to know, or what does a listener need to know who's a practitioner about entryway with your unit?
Yeah. I mean, the first thing is, I mean, I developed this unit many years ago, and people will notice I don't actually sell it, and the reason being is I would like to, of course, I need pay my mortgage and pay my bills, but you'll find I never sell it, and that's because I don't want to. I'm more a scientist than a commercial animal. Although I'm in private practice and I need to earn money, and I enjoy that, and I love working with patients, which is why I'm in private practice. The reason why I don't push it massively is because I don't want to mix the commercialism with the scientific side of me. And I wish I was more scientific. I wish I was more academic, but I'm not. I work in private practice. So I don't have the time, although I'm about to start some research with Keele University. The first thing you need to do to get into the pelvis, and I would absolutely advise any musculoskeletal practitioner to make sure they understand the pelvis. It's a long journey, but start with the basics, because the passenger unit sits on the sacral base, the sacral promontory, and it's that big. So the rest is soft tissue. So if the pelvis isn't right, then the torso is not going to be right in some way. And the legs articulate from the pelvis. So if the pelvis isn't right, the leg articulation to the foot isn't going to be right. But I would say as a starting point, open the mind and look at pelvis. So when you have a patient in front of you, get the guys to take the t-shirt off, ask the ladies if they don't mind exposing a little bit of the top of the pelvis. Obviously, talk them through everything, talk everyone through. I say to all my clients, I'm going to place my hands here on top of the pelvis. So really clear about what you're going to do with your clients, but just look. And the best thing you can have, the best tool you can have to start to learn is something like an 8mm EVA board, bigger than the size of the biggest foot. A board like this. And look, so get the patient standing in front of you, look at the pelvis, so you can see any asymmetry and foot function, pelvic position, and shoulders and head. Turn them around, look at them from the back, look at them from the side. That's the first thing, the most basic thing you can do. Then you take your board, and you can use 3 magazines, or you can open up a book if you don't quite have a board. But if you've got a lab, you can say, can I have a small piece of 8mm EVA? The reason 8mm is you want it to be slightly more than the average across the planet. So the average across the planet is about 6mm. So you want to be a little bit more than that to have an exaggerated effect. Because if you use 2mm, they wouldn't notice it. And then what you want to do is say, right, just stand on the board and start with the short leg first. The reason is, if you start with the long leg and there's already adaptation there, you push it further into adaptation, it'll hide itself. But if you start with the short leg, the body will pick up the change in newtons going into the hip joint, and it will unadapt a little bit. So you look at them and you go, oh yeah, you look a bit better like that. How does it feel? And they'll go, yeah, it feels okay. A little bit high, but feels okay. But because the pelvis in those few seconds is unadapted, because the change is quite quick, because of the seesaw effect that acts on the pelvis, when they stand on it with the long leg, they'll go, whoa, that feels high, if they've got a difference in leg length. And that gives you a vital piece of information. It tells you, there's an asymmetry here, and the patient feels the difference. So it opens up your mind to looking extrinsic to the foot. What it doesn't tell you is what type of asymmetry it is. That takes more skill, and whether you need to intervene. But then if you want to go to the next level, you'll say, can I put my hands on the side of the pelvis? And you don't need a digital pelvic inclinometer for that. The best tools you have is the proprioception of your fingers to your cerebellum, and put the hand on the side of the pelvis on one side, but don't do it standing because you're looking down. Get to eye level, so get like a kneeling pad, like a gardener's kneeling pad to protect your knees, because I've been doing that for many, many years, and I still got good knees. Put your hand on the side of the pelvis on the asis to piscis axis, then go around the other side and do the same. And then you've got 2 pieces of information. 1, I can see a difference. 2, patient feels a difference. 3, there's an asymmetry. Then hands at the back on the piscis, on the sacral base, and you'll see a difference, one way or another. Then you've got an additional piece of information. That's what I would do to start, and then go and read the literature.
Well, Clifton, that's brilliant. Listen, this has been 45 minutes is shot right by. I want to thank you for you doing this today, and I want to personally
Thank
invite
you.
you to our next biomechanics summit in 24.
I would love to.
Date to be determined, but and we'll have to work the time zones like we always do. But I would love if you're able to have you present on a topic of your choice. I'm sure Pelvic will be part of it.
Yeah.
Any parting thoughts that you'd like to leave us with before I'll let you have last word?
Oh, okay.
And
Thank
also
you.
to give your resources. I always like my guests to be able to connect with them if you wish.
Okay. The first thing is, I'm just about to complete a training course on sacroiliac joint and pelvis. I've been working on it for about 9 months. Hence why I've been up early and working till late. And that's going to be an online modular course with video commentary, a bit like this. So I'll be talking about every slide. So that's going to be available in a few days' time. So I've already started taking bookings for that. But as a parting gesture, I believe that asymmetry in the skeleton of whatever format and whatever origin is one of the biggest causes of overuse injury and abnormal forces within joint complexes. And I would highly recommend that you try and understand them and balance them if you want to eliminate injury, because also as well, don't just look at people on a couch. You're not seeing anything. At least have them stand and walk. And if you have a treadmill and technology, fantastic. But you are not going to see anything lying on the couch. Try and do as a dynamic assessment as you can, and consider leg length as a possible origin behind the injury of the client that you have in front of you.
That's great parting words, and I'm sure
Thank you.
everybody out there listening is going to you've piqued their interest. You certainly piqued mine, and I look forward to future conversations and hopefully having you at the Biomechanics Summit that I'm going to be putting together next year. Thanks again,
Thank you so
Clifton.
much.
It was a lot of fun.
Thank you. It's been great talking to you, Ben.